Everybody, it's Dr. Eric Balcavage and Dr. Erica Riggleman. We're here again with another episode of the Thyroid Answers Podcast. And today we have Lisa Hendrickson-Jack, right? And she is really, I guess you'd say, like a fertility awareness educator, right?
That's right.
So can you give us a little background of what that means to the general listeners and give us a little bit of background about you so people understand why you might be an expert and a good person to talk to, because we're going to get into how fertility, talking about menstrual cycle and how it ties in with thyroid physiology.
Yes, absolutely. Well, thank you for that. So how I wound up in this field is that I discovered fertility awareness when I was quite young. So I was just out of high school. I joked that I was in my post-high school feminist phase, and I was attending all of these really interesting talks at my university. And so I wound up at this talk, and this woman was describing the menstrual cycle essentially. And she just mentioned kind of in passing that, you know, as women, we're not fertile every single day of the cycle. And there's actually a small window of fertility that we can learn to identify. And then with that knowledge, we can determine whether or not we want to get pregnant. So if you can figure out when you're fertile, you can choose to manage that window and not conceive without hormonal birth control, or you can obviously time sex correctly when you're trying to conceive. But the bigger aspect of it is that the menstrual cycle reflects overall health. So you can also monitor your menstrual cycle as a way of keeping track of your overall health, because it responds to different health challenges that you're having. So for me, that was exactly what I was looking for at that age, because I had been put on birth control for heavy periods and painful periods, but I saw, you know, members of my family, my mom, some of my aunties have various challenges with their menstrual cycles. And I kind of was worried. I was like, okay, if I'm going to be on this thing, is it going to affect my fertility? So it was kind of around that time I was looking for an alternative. And so I promptly started charting my cycles. And then I just happened to be located in an area where on my university campus, there was monthly meetings for these women who were, you know, trained instructors were holding monthly meetings. So I attended, and then I took a training program, and then I began teaching. And here I am, you know, almost 20 years later, still in the field, because even though I've been abreast of this knowledge and teaching it for so long, the average woman still has no idea how her cycles work, how it relates to her thyroid function, or just health in general. So I'm happy to be here with you today.
And so it didn't take long for you to figure out that if you have an abnormal cycle, that's a problem. And taking birth control to organize your bleeding cycle doesn't mean you fix the problem, correct?
Well, that's right. In my case, because my periods were heavy and painful, I wasn't taking the pill for birth control as a teenager. And so I would often take breaks from it or whatever the case. And every time I would stop taking it, I would have the same pain or worse pain. So, and I had a really skeptical father, and every now and then he'd be like, "Are you still on those pills?" So I just kind of had this sense that it wasn't actually fixing anything, that it was just covering up.
Yeah. Mm-hmm. Yeah. I think there's that misunderstanding that to some degree in allopathic medicine that, hey, as long as we organize the bleeding cycle, we've fixed everything. And the reality is we haven't really fixed anything. And maybe we've actually promoted more dysfunction in the body by doing that. So that's part of what we're going to get into.
I also think that there's a misconception even in teenagers or even in young adulthood that that's just normal. That's what all women go through. And so people don't often look at that as a bad thing. They're just like, oh, it's just what happens and you just have to deal with it. And, you know, or you could take this to kind of cover it up. And I think that, you know, what you're promoting and letting people know that that's not normal and that there's a reason why this is happening and that this could be meaning that there's something impacting your health, I think is a great thing and something that maybe all women kind of need to know.
Well, I mean, absolutely. And I think a big part of this conversation is dispelling a lot of the myths. So the myth is that when you take the pill, it gives you a regular menstrual cycle. And so a lot of women think that when they're on the pill, they're actually having a menstrual cycle, except that in order to have a menstrual cycle with a true menstruation, you have to ovulate. So we often think of the period as the most important part of the cycle because, I mean, it's red and it's very obvious. It gets all the attention. But really, the main event, quote unquote, in the menstrual cycle is ovulation. That's how we produce our main ovarian hormones, estrogen and progesterone. So we make estrogen as we approach ovulation, progesterone only after ovulation. So when you're on the pill, or other types of hormonal birth control, most types of hormonal birth control either fully suppress ovulation or at least interfere with normal ovulatory function. I mean, otherwise it wouldn't work. So that's
Right.
a big part of why it works and is effective. And so when you're on the pill, if you're taking your 21 days and 7 days of sugar pills or the patch or the ring and removing it, you're getting a bleed, but it's not an actual period. It's a withdrawal bleed that happens. It's your body's kind of response to a sudden drop in the synthetic hormones. So even just getting some of those myths out of the way, I think when I talk about this stuff publicly, a lot of women, they kind of react like, no, what do you mean it's not a period? Of course it's a period, but it's not actually a period.
Yeah, I think you can define it as like a bleeding cycle versus a menstrual cycle, right? They're
Absolutely.
two totally different things. And I think people, if you grow up in a family where everybody's got long periods or heavy periods, you kind of, like Dr. Egger said, you kind of consider that it's normal. Everybody around me has it. But normal and common are two different things, right? So we need to make sure we understand that just because you're having heavy cycles and your mom has had heavy cycles, that's not necessarily the norm. Just like if you don't have a bowel movement for 3 days and neither does your mom, that's not normal either, right? It's an indication of a problem. So let's get into it. You wrote a book called The Fifth Vital Sign, right?
Yes.
And so we need to discuss probably two things. One, for the listeners, what's a vital sign? What's the fifth vital sign? And what was the emphasis for writing the book?
Well, thank you for that. Two of my favorite questions. I mean, in general, a vital sign is a measure of how a measure of how your body is functioning. So the most commonly known vital signs, I don't have to tell the two of you,
Right.
but the most commonly known and accepted vital signs are your heart rate, your body temperature, your respiratory rate, and your blood pressure.
Right.
And so, anyone listening can recognize that when you go to your doctor and they're taking your vitals, we have an established set of what is considered to be normal. So we know what a normal blood pressure would look like. But in addition to that, if your blood pressure was, say, too high or too low, not only would it give us an indication that there's something wrong, but it would give us a specific indication of where to look. So as a doctor, okay, if blood pressure is too high, there's these few things that we're going to look at first, and with all the other vital signs. So when I say the fifth vital sign, I mean, in the book, I'm arguing that the menstrual cycle is a vital sign. And I'm not the first person to say that. It's becoming more known and accepted that we should be paying attention to the menstrual cycle as a sign of health. So when I say menstrual cycle, I don't just mean period. I think a lot of women, when you say menstrual cycle, they just assume it's only their period. So when you break the menstrual cycle down, day one of your cycle is the first day of your period, your first day of true flow. I usually say when you have to do something about it. Some women may experience some spotting before their period, but we're going to consider the first day of true flow. So you have your period, and then after your period stops, you're entering into your pre-ovulatory phase, so the first half of the cycle. And over the course of the first half of the cycle, at some point you would expect to see some cervical mucus for a few days, that I'm sure we'll talk about a little bit. As you approach ovulation, ovulation is crucial for the cycle to be normal, and then the second half of the cycle, the luteal phase, would be about 12 to 14 days. So when you break the cycle down into the different components, then you can start to appreciate even more how the cycle could be looked at as a vital sign. If there's something wrong with the period, if it's too heavy, too light, too short, we can look at that. If you're not having any cervical fluid, if you're having some sort of discharge every single day, those things are outside of normal. If you're not ovulating, if you're ovulating a lot later in the cycle, if it's being delayed by a variety of different factors, if the second half of your cycle is too short, if you're experiencing bleeding throughout, et cetera, et cetera. So I think step one is understanding that just like all the other vital signs, there's an accepted range of what we would consider normal. And second of all, not only would it give us some information in general, but if there's specific things wrong with your cycle, you can actually point to specific issues that you should be paying attention to.
Yeah, it's a great answer. And I think one of those things that kind of sparked a little thought process in my head is when you're talking about the other vital signs, we have a tendency to do with those vital signs what we do with abnormal menstrual cycles, which is, hey, let's organize the number, right? You have high blood pressure, let's lower it. So we have a tendency to try and normalize those things. So we say, hey, the patient's better because we normalize the number. And the patient's not necessarily better. We may have kept them alive, but we didn't necessarily make them better. So we have to step beyond just trying to normalize a bleeding cycle and actually ask the questions like, okay, why is this happening, and what can we do to actually fix the cycle so that it's functioning appropriately. And one of those things you have to do is understand that cycle, which is kind of what you just laid out. So that was a good point. So you kind of laid out the kind of normal menstrual cycle, right? And how that cycle should be. What do you see as the most common disruptors of the menstrual cycle?
Well, I mean, that's a really good question. I would say that it depends on the woman and the cycle, but some of the most common issues that disrupt the menstrual cycle, thyroid is one of the most common issues that does disrupt the menstrual cycle. So low thyroid function can have an impact in cycle length, in the quality of the menstrual period, and of course in body temperature. So, that's a pretty significant factor. When women have issues with insulin resistance or glucose sensitivity, in the case of PCOS, for example, the menstrual cycle is highly susceptible to that. So for instance, a classic PCOS cycle is one where ovulation is often delayed. Cycles are often higher than 35 days, and or there's a huge range of the cycle. So maybe sometimes it's 35 days and sometimes it's 52 days or certain things like that. Stress is a really big factor, both chronic and specific. And so depending on where you are in your cycle, if a woman experiences like an acute stressor, something happens, it can delay ovulation. If she's post-ovulatory, it can shorten the luteal phase or cause some degree of bleeding. And of course, when we think of stress, we think of, okay, car accident or something kind of emotional, but there's other types of chronic stressors that we wouldn't necessarily think of, like chronic inflammation or food sensitivities and allergies and things that can be increasing the cortisol, but we don't necessarily think of it as stress. And other health conditions, I mean, what's interesting in my world is that because I'm always looking at the chart, you start to see different things that can be affected. So I've seen situations where women are sensitive to certain foods and they consume them, and they end up with like a chronic mucus pattern. So they'll have like mucus all the time, and we're trying to figure out why, and then they'll make some changes, identify food sensitivities with their functional practitioners, and then kind of work on that, and then we'll see that normalize. And then one other thing I'll mention as well is, say in the case of hypothalamic amenorrhea, which is characterized by a combination of overexercise, undernutrition, and stress. And so you have cases where women may be exercising excessively, not eating enough to cover the deficit, or not eating or not eating enough, and they lose their periods altogether. Often they're put on birth control to make everybody feel better that they're having a regular bleed, but ultimately, I feel like that the example of HA is such a clear kind of cut example of how the menstrual cycle can be like a vital sign, because when you have HA, you rapidly lose bone mass, and so it's a pretty serious issue that indicates an underlying problem.
Yeah. The interesting thing is a lot of the things that you just mentioned, they impact the cycle, but those are the same things that also impact thyroid physiology. A lot of, whether it's stressors, inflammation, food sensitivities, they're all affecting at the cellular level, and they can impact that thyroid function. It almost becomes like a vicious cycle where we start to impact thyroid function. Thus, you're going to impact the cycle. Then the cycle impacts it. It just kind of all ties into each other. And so I think the big thing to take away from this is that there's so many things that can affect each other. And, we often don't think of those external things that can impact the cycle or even thyroid function.
Yeah, I want to tie into that for the listeners. I think one of the things we make as a common theme on the podcast is that cellular stress, and it doesn't matter if it's physical, chemical, emotional, microbial, poor breathing and hypoxia, anything that triggers cellular stress is going to trigger cellular hypothyroidism. And so the gland can still be functioning well. And that's the challenge. And Lisa, you probably see this in your practice where they may have normal TSH, normal T4, T3, but they still have problems with their cycle. And they could still have cellular hypothyroidism, which is affecting the tissue. And if nobody's looking at things like reverse T3 or the T3 reverse T3 ratios, you miss it. You don't see it. And if they have inflammation, maybe they are starting to develop hypothyroidism at the HPT axis, but the inflammation is suppressing the TSH, and so it doesn't get seen. And so I think what listeners have to keep in mind is that when we're talking about hypothyroidism, and definitely when Dr. Eric and I are talking about it, we're not talking about it particularly at the gland level. We're definitely talking about it primarily at the cellular level and what happens. And it's I'll just kind of hit on a couple points of how hypothyroidism definitely impacts it. So we kind of tie those things together. When you have, especially when there's an overt hypothyroidism, you're going to have an increased levels of TRH, thyrotropin releasing hormone. That's going to increase TSH, and it's also going to increase prolactin. And prolactin then is going to decrease the synthesis of FSH and LH, and that's going to impact your gonad. So you're going to have some decreased function of those tissues. You're definitely going to throw off your peripheral aromatization. That's going to be changed. If you are hypothyroid, you're going to have a tendency for decreased sex hormone binding globulins, which is going to cause a decrease in total estrogen and testosterone, and you're going to have increased free hormones available. And so, as Lisa mentioned, you can have your cycles. You can have the oligomenorrhea because your cycles are just prolonged. But hypothyroidism or hyperthyroidism can cause short or long cycles. But it's really the impact that's happening at the cellular level, not necessarily the thyroid level or even what you see in the blood. It's about what's happening in the cell. So that's so important, I think, for us and for our listeners. So from a hypothyroid standpoint, at the cellular level, almost every aspect of fertility cycle can be impacted. Even the oocytes have receptors for thyroid hormone. So the that development can be compromised as well. So I'm glad we got a chance to touch on that.
Well, and can I just mention, one of the challenges, because in my practice, my role is really to support women to understand their cycles and to identify some of the issues that we can gather from the cycle. But of course, when I'm working with women, they're working with a team of practitioners. So they're working with their medical doctors and they're working with their functional practitioners. Mm-hmm. So one of the challenges that my clients face is when you have these labs that are totally normal, right? If the doctor was willing to run them all, not all doctors are willing to run the reverse T3 or the antibodies or whatever the case is. So the labs are normal and they're told everything is fine. But then when we look at the actual chart, we may still see temperatures that are far too low, an indication of low metabolism. We may still see signs of potentially low hormone production. Mm-hmm. So, with the chart, it's an interesting kind of phenomenon. So signs of, like, for instance, low estrogen, you may have really limited mucus production and you kind of looked at all the reasons for it, but you're not, you've kind of crossed everything out. You might have low progesterone production in the luteal phase. So signs of that. So either a short luteal phase or you might have some spotting. So you still basically have these signs of potentially low thyroid function, but the labs are all fine and all that kind of stuff. Right. So just to point out that with the menstrual cycle, one of the things that I found just over the years in the work that I do is when you actually hit the problem, when you've actually addressed it, when you've actually identified it, then you see the cycle respond.
Right.
And so it can be really frustrating. And I think one of the biggest challenges for the women who are hip to this and who understand that is finding a practitioner who will work beyond the labs and help actually look at their own body as a valid sign of what's happening with their health.
Yeah, I think that's key. And unfortunately, we talk about this as far as labs, reading a lab report and interpreting a lab report. They're two totally different things, right? And so you can look at a lab report. If it doesn't say H or L on it, then you assume that everything's good. But we have to interpret labs based on the person who's sitting in front of us, right? If you're tired, fatigued, your menstrual cycle's disrupted, and everything's normal, then those labs, even though they're normal, they're inappropriate for the person who's sitting in front of us. And our job as doctors or advocates for our patient is to help them understand that it is not normal to have these types of symptoms. It doesn't matter what your labs are. And there are many things that can make lab values look normal when they shouldn't be. And inflammation is a great indication, especially when it comes to TSH. The inflammation will suppress it. Last point on that, and then we're going to start talking about the charting part that you were just mentioning, is anytime your cells are under cellular stress, the body, you have this net effect of cellular hypothyroidism that goes on, and that's not an accident. That is on purpose. And so if the cells are in stress, the body is not in a mode to then say, hey, we're under attack, we're under stress, let's have a baby. That just is not the normal physiology. We're in protection mode. We're not going to slow down to take a nap. We're not going to have a great night's sleep. We're not going to have great digestion. We're not going to have normal hormones because those are not key things that are needed for cell protection. The body shifts the thyroid physiology away from those actions and towards producing inflammation and oxidative stress and cell defense. And so people need to make sure that the reason we talk about these things like working on your diet and nutrition and sleep and emotional state and respiration is because those are the things that can trigger the cell stress response. And there's not enough drugs and hormones in the world to fix you if those things aren't working. So off the soapbox, and now back to you. And that is, you started talking about charting. So talk to us about charting your cycle and how to do it and why that's important.
All right. Well, I mean, when you're charting your cycle, we're looking at the three main fertile signs. So I think one thing to point out is that there's no one universal fertility awareness method. There's multiple different fertility awareness based methods. And so, for instance, if you're working with someone who is trained in fertility awareness charting, there's different programs. So I was trained in the Justice method, which is a version of the symptothermal method. So when I'm teaching women, we're looking at all three of the main signs. So we have your cervical mucus, which is the primary sign of fertility. And the reason for that is that cervical mucus can keep sperm alive for up to 5 days. And so often what women are taught or told is that when you're trying to get pregnant, you're actually trying to have sex on ovulation day. So there's often this idea that that's the best time, like that's what you're trying to do. But when you understand how the body works in the physiology, you appreciate that the best time to conceive is in your fertile window. So that's why cervical mucus is the primary sign. Basal body temperature is very helpful. That's a measure of your resting metabolism. So you would take your BBT first thing in the morning before you get out of bed. And I mean, that's one of the reasons why with charting, when women start charting, they can often pick up issues with thyroid because they're inadvertently checking their metabolism every day. And so once you ovulate, you produce significant amounts of progesterone, and that has a thermogenic effect on the body, so it raises your body temperature. So it's really neat that you have this very scientific thing that you can do in your house where you can actually check to confirm that you've ovulated. And then cervical position is an optional sign. And so not all women necessarily check it, and it's not necessary, but it can be very helpful as a third sign to kind of triangulate the other two. So your cervix changes position and texture depending on where you are in your cycle. And so when you're charting your cycles, one example, I just want to go back to the cervical mucus for a minute because I just hear all the myths all the time and I get a lot of questions. And so an example that I like to share just to kind of set it home, especially for women who are listening who are trying to conceive or are thinking of conceiving in the future. When, for example, if you were to see, you're charting your cycle, you're checking for mucus every day. If you were to see cervical mucus on Monday, and you were to have sex with your partner on Monday, and then your partner had to like leave for business or something like that, and you didn't have sex again throughout the rest of your cycle, you could, and let's say you ovulated then on Friday, so you saw your cervical mucus on Monday, it can look like clear, raw egg whites, kind of stretchy, or it can look like creamy white hand lotion, but you don't actually ovulate until Friday. You can actually get pregnant on Friday from the sex that you had on Monday because your cervical mucus can keep the sperm alive for up to 5 days. So when you're trying to understand the cycle, how it works, trying to get a sense of what this whole charting thing is all about and how it could help you conceive or how it could help you avoid pregnancy, that's an important thing to understand, that when you're timing sex, it's not necessarily all about getting it on ovulation day, but timing it with your cervical fluid observations.
Okay. Awesome. So go ahead.
So when women are thinking about, obviously getting pregnant, and usually this sort of stuff is going to come up when they want to, when they're thinking about fertility. Should women wait till then to start charting, or is this something that they should be tracking long before they're trying to conceive?
Well, I mean, ideally, it's a good idea to start tracking your cycle before go time, before it's like you're right at that time, for a couple of different reasons. I would say that, I mean, in my book, I talk a lot about the birth control pill and the effects that it can have on fertility. And so there's no research that would indicate that the birth control pill or other types of hormonal birth control has a permanent effect on fertility, but it is associated with a temporary delay in the return of normal fertility. So in terms of tracking your cycle and getting a good understanding of how it works, it is a good idea to, if you're planning to conceive in the next couple of years, to start thinking about when you're going to come off the pill. I mean, I would recommend 18 months to 2 years. That's a long time. I know that might seem like a really long time to recommend, but for some women, if you were put on it because you did have cycle issues, and we already talked about how the pill doesn't fix or solve any of those things, if you did have some underlying factors there, coming off the pill early and starting to get a sense of what your actual cycle is like is a good idea before you're ready to start trying to conceive, because you just don't know how long it'll take for your cycles to come back or for them to normalize. In a more general sense, just having an awareness and understanding of your body and your cycles before you're ready to start conceiving is a good idea, because when you think of your menstrual cycle as a vital sign, if you did notice that there was anything off, if some of the signs were falling outside of normal parameters, if you had signs of impaired thyroid function, or if you had irregular cycles, meaning that your cycles are varying more than 8 days from cycle to cycle, or you're having more serious issues, it would give you an opportunity at least to look at some of those things before you're ready to start trying.
Absolutely. And I would definitely agree. I think the sooner you can catch things, the easier it is to kind of get you back on track. And I think that goes with anything with your health, being aware of your body and knowing the signs. It's kind of the same thing with thyroid function, is that if you wait till half of your hair is fallen out and you've gained 50 pounds and, you've had thyroid issues for years now, it's harder to get you back on track. There's so many things that have compounded at that time, as opposed to when you initially start noticing a little dry skin, or, my cycle's a little off, or maybe a little bit of my hair is falling off, and, taking the initiative to maybe go get some testing to see maybe what baseline is, so that if you do have an issue down the road, you have something to compare it to as well.
Well, and one of the things to mention, just in general, post-pill, I'm not sure how much you talked about it on the show, but the pill is associated with suppressing thyroid function. And so for some women, when they come off the pill, or for many women, they come off the pill, they may have signs of low thyroid function. It may not mean that they're necessarily hypothyroid. It may mean that they're in the period of transition as their body normalizes and begins producing those hormones again. So when I was looking at this effect of just how does the pill affect fertility, and how long does it take for the cycles to normalize, there's a few different ways that it's looked at in the research. So one of the ways is to look at the actual cycles and how long it takes for the cycles to fall into normal parameters post-pill. And so in this, one of the studies that I looked at, it took an average of 9 to 12 cycles. So they had a control group of women who had never used hormonal birth control, and then they had a group of women who had used it. So an average of 9 to 12 cycles before the cycles all kind of looked the same. And so they were looking at the total length. So often the first several cycles post-pill are a bit longer because ovulation is delayed. And they're looking at the luteal phase length. And so it's very common the first couple cycles off the pill for the second half to be too short, and that can interfere with implantation and your chances of conception. And so I think even that is interesting. And I always point out 9 to 12 cycles isn't the same as 9 to 12 months. Because a woman may not get her first, some women start, they might get their first period right away. Other women, it might take a month or 2 months or 3 months or 4 months. So it actually is more like 12 to 18 months when we say 9 to 12 cycles. And then another way that is looked at is how the time to pregnancy studies, where they actually have women come off the birth control and see how long it takes them to conceive. So I know I often conflate the, pill use with charting, and it's how I talk about it a lot. But a lot of women are on the pill for a long time, and it's often when they're trying to get pregnant, or when they're in that mindset, that's when they're finally coming off of it. So I always find that it's important to talk about these things together.
Yeah, I think there's a couple things we should kind of touch on right as we talk about that. We just kind of hit on the pill, and whether it's the birth control pill or hormone replacement therapy, the couple things to consider when we're talking about estrogen and its impact on thyroid physiology. One of those is you increase estrogen loads, you're going to increase thyroid binding globulin. So you're going to bind up more of your thyroid hormone, T4, T3. So the blood levels could look normal, but your free hormones, which are the ones that actually have the access into the tissues, are actually going to go down. When you take estrogen actually has an inhibitory effect on iodine transport into the thyroid gland. So it shuts down something called the sodium iodine symporter. And the impact of that is then that you can't make thyroid hormone. So it decreases the global impact of what the gland can do. So it decreases T4, T3. And women have to be aware, especially if they've been diagnosed with thyroid nodules, that part of the reason why they may have developed thyroid nodules may be because of their estrogen therapy that they're on, whether they're on birth control pill or hormone replacement therapy. The other way that estrogen is really going to have an impact there is that estrogen, as you increase estrogen, especially if you're not able to metabolize it appropriately, because decreased thyroid hormone decreases your detoxification pathways, estrogen will then increase something called deiodinase 3. So deiodinase 3 is the deactivating hormone. So estrogen can can impact thyroid hormone almost at every stage. It decreases the production, it decreases the available free hormone, and it increases the D-kinase 3 or the deactivation of thyroid hormone. So there's multiple ways that being on birth control or hormone replacement therapy can slow down thyroid physiology. And maybe on purpose, because there is a kind of a shift in thyroid physiology when you are trying to get pregnant. So that kind of makes sense. But the problem is, if you're not trying to get pregnant, you don't want to be shutting down your thyroid physiology. And it can take some time for that physiology to kick back into gear, as Lisa was saying. So great points there.
Can I say something? I love that you referred to it as estrogen. Often women don't even think of birth control as medication. Mm-hmm. And so calling it what it is very helpful, like a synthetic estrogen that you're flooding your body with that has all these negative effects that you wouldn't necessarily think of. So I just thought I'd mention that because it's really nice to, I think it's so important to just call things what they are and talk about what they do.
Yeah. I think most women don't even realize that they just think it's some magic pill that just shuts off ovulation, that they don't realize that it is a hormone. You're taking hormone replacement essentially.
Well, and I don't think, I think the problem is how we've educated people, right? And it's, the doctor's been taught a certain way, and the lay people have been taught, hey, this is the fix. And so, hey, if you take this, it'll organize your bleeding cycle. All will be good. You won't get pregnant. Life is good. There's no problem. Nobody's really spending the time to read that little tiny packet, actually the big packet that comes with this stuff, and all the little script in there that you can't even read that tells you all the potential side effects. And so that the problem is that we're all looking for the easy way to do things. We all are. And the problem is the easy way often has negative ramifications. Because it's easy, it always means that there's typically some type of effect or side effect that we don't want. But it's hard to blame a female if they're struggling with hormone cycles and they're going to an expert on physiology, supposedly, right? And they're saying, this is the fix. I mean, you're trusting in your doctor to be doing the right thing for you. And that doctor is doing exactly what they learned in medical school. And they're saying, this is the treatment. And so I hate that sometimes, and I do this all the time, we want to make sure that we're not like disparaging anybody. The problem is that it's the dogma. It's the way the system is set up. It's not necessarily the individuals within the process, whether it's the doctor or the patient or the people in between. It's just the system is screwed up, and it doesn't matter whether it's hormone therapy, birth control, or high blood pressure. We're stuck in this acute model treatment mode where, hey, we got to stop the bleeding or we got to organize it, and then it ends there. And I think that's the problem. So for women who are really struggling and saying, well, I needed it. Well, we would not give you any type of hard time for saying, hey, you're having pain, you're having abnormal cycles. It was a way to support yourself or try and balance it out. But what we're really saying is you got to look beyond those things. If you're doing it not to get pregnant, okay. Lisa would probably tell you there's other ways to not get pregnant, right? But there's also, if you're doing it to normalize your bleeding cycle because it's just hard to deal with and hard to live with all those symptoms, we urge you to take that next step, to ask that question, okay, why is this happening? And what can I do through diet, lifestyle modification to make some of these changes? So,
Well, and can I jump in there? Because
absolutely.
I'm very vocal about the pill. Vocal in my podcast, vocal in the book. And so often it can come across that I'm like totally anti-pill, and someone could think, oh, she would say no one should ever use it. So just to clarify, that's not my stance. I'm the reason that I talk about the pill and the reason that I talk about the side effects, as I'm sure similar to the reason you talk about it, is more because I want women to be informed and I want them to have the ability to make an informed choice. So it feels like our culture has been very much, we want to give women the right to not get pregnant, right? And unless we want to. So we really focus on that. But what I also think is important is the right to get pregnant when you want to.
Yeah.
And so I think that when you educate, and there's also a trend in the medical, in the research as well, and in the doctor's office, to kind of shy away from being honest, completely honest about the side effects, for fear that we're going to scare women away from using birth control. And so I think that if we just educated women about the pill and all of the side effects in all earnest, that women would fall into 3 categories. So some women would say, okay, this doesn't feel right to me, and I don't think I'm going to use it. Some women would say, oh my goodness, I'm so glad I know, I'm going to take it. And then if I do experience these side effects, at least I'll know it could be related, and or they may modify their use. So a lot of women might still take it, but then when they're ready to get pregnant, they might just modify their use, come off of it a little bit earlier, just in case it takes their body a bit of time to normalize, but at least they know. And then some women would just take it for just as long. And I think that's the conversation that we need to be having. So when you, just as a woman and also having female friends, in the research, it's often minimized because the birth control pill is reversible, right? So it's like, okay, we know that the cycles normalize, or they'll say in the study, like within a year, all of the participants, their cycles normalize. When you're dealing with an actual woman who has been actively avoiding pregnancy for her entire life because she was taught that she could get pregnant every single day, which is not true, then she is terrified of coming off the pill until she's ready to have a baby, because she's convinced that the minute she comes off the pill, she's going to get pregnant. So what happens is she comes off the pill. Some women get pregnant right away, as we know, but some women do not. So the first month they try, they're okay, but by the second month, they're a little nervous. By 6 months, they're in their doctor's office, and by 12 months, they're already getting fertility treatments. So if it can take 9 to 12 cycles, 18 months, 12 to 18 months for the cycles to normalize, we need to tell women so that they have the opportunity to know and to make those choices. When you're 37 years old, you don't have the option to go back in time and take an extra 2 years, even if your body happens to need it.
Yeah, and I think we have to, the mindset of a 21-year-old female or a 16-year-old female is different from the mindset of a 35-year-old female who's going, okay, now I want to do something. When I was 16, I just didn't want to get pregnant, or all they kind of cared about was not bleeding through my clothes, right? And so I think the key point is it's all about education. And when Dr. Erica is talking to, about what our understanding, I think the easy thing is we all understand on this end. And we just want to make sure our patients understand that the more informed they are, the more action they can take. And if they choose not, hey, this is just what I want to do, great. But you should understand what those potential outcomes are. And I think we owe it to women who are taking these things, not to just put them on at once and just let it go, but to continuously remind them, hey, remember, this is not fixing anything. And if you decide to get pregnant, we're still going to need time to fix whatever it was, and you're going to need time to recover from what this just being on these medications has done. So I think both of you guys kind of hit the nail on the head. Is we have to make sure we have more informed and more educated patients who are understandably more receptive to that message at different times in their life and be aware, right?
Yeah, I think the education portion is really, really important. There's just like, everybody knows smoking is bad for you, but there's still people that smoke. But as long as people are educated and know the decision that they're making and know the ramifications that can come from it when you want to come off of it, because some women come off birth control and don't even realize, they just think they're going to get pregnant like that. And again, like you said, 2-3 months go by and you're not pregnant, and that stress kind of sets in, and then the stress causes more cycle issues, and all that stuff just adds up. And so the education portion, I think, is really, really important. Let the patient decide if they want to do it, but I think that in our society we need to do better of educating what side effects are, not just from birth control, I think from all medications patients take, but I think that's, and then letting them decide if they want to take it.
Well, and I just love the point that you made, Dr. Eric, about how your mindset changes with age, but the education doesn't. So you're right. Like when you're 16, 17, 18, it's a completely different mindset than when you are 30. And so, controversial or not, one of the things that I encourage women to think about is when you actually get into your late 20s and early 30s, it's time to start just actually thinking about how you want to manage your fertility, like what that contraception should look like. It doesn't mean you have to change and go, give up hormonal birth control if you're comfortable with it, but it's important to have that conversation with yourself. I think many of us, I can think of different examples, but there's certain things you kind of start doing, like you get in habits when you're young, and then you don't necessarily reevaluate them, and you get older and they might not fit anymore. And so I feel like this is the time when you're in the late 20s to early 30s, you know you want to have a baby at some point, but not today. It's just time to start having that conversation with yourself. Like, it is a medication. It is impacting your hormones. It could be affecting your thyroid hormone. It can be affecting a lot of different things. It could be masking an underlying issue. So have that conversation with yourself about how you want to manage your fertility. And then another important part of it, you know, given in my field as a fertility awareness educator, is that a lot of women really don't know that there are alternatives that are non-hormonal that are effective. And so, of course, I've spoken to a lot of women who at some point felt trapped. So not all women have negative side effects that they can identify, but some women do. So there are women who are going from, you know, pill to pill to brand to different types because they're looking for something that doesn't give them whatever effects they're experiencing, but they feel like there's no other option. So when you look at fertility awareness-based methods, again, there's different types, but when used correctly, so for instance, the symptothermal method, you know, what the research tells us is when used correctly, up to 99.4% effective. That's not the same as how we think about the rhythm method. We could talk about that if you want, or how people often think about fertility awareness. And we can combine, you know, fertility awareness knowledge and information with barrier methods. And there are, you know, hundreds of thousands of women who successfully use a non-hormonal method to prevent pregnancy while preserving their natural fertility. So if anything, you know, one of the messages I want to share is just that it is possible. It's not for everyone. Fertility awareness, I mean, that's why we have all these different types of birth control options. So there's no one method of birth control for everybody. And I know better than anybody that fertility awareness is not going to be for every woman, but for the women who gravitate to it and who self-select, the ones who are motivated to do this and who love the idea of charting their cycles and really gravitate to that, just the biology of it, like, wow, I'm not fertile every single day. Like, I can actually empower myself to learn how to manage this. It's important to know, like, this is a very real option for women.
So fertility awareness is really being about understanding your cycle, understanding what a normal cycle is, and then understanding when you can't or are less likely to become pregnant. So you're talking about the rhythm method and a temperature method. So can you explain maybe the top 2 or 3 methods that people can use in the process?
Well, so I'll get the rhythm method out of the way. So the rhythm method is a calendar method. It's not the same as fertility awareness. And so the rhythm method is based on the idea that if we chart a couple of cycles and we get a sense of how long they usually are and when you usually ovulate, that we can then guess when your ovulation will happen. So the rhythm method is based on that idea. So a lot of women, even when they're embracing the concept of fertility awareness, are still kind of rhythmy in their thinking, because often we still think, oh, the cycle is always 28 days, quote unquote, always 14, or always ovulating on day 14, quote unquote, which isn't true. The average cycle is about 28, 29 days. But as women, when you chart your cycles and when you pay attention, even the woman with the most regular cycles will have some fluctuation. So the main difference between, say, the rhythm method, which is the calendar and the calculation, and the fertility awareness method is that with fertility awareness, you're charting your signs on a day-to-day basis. And so at the end of each day, you're basically saying, am I fertile or not today based on what I saw? So with the method that I teach, we're looking at cervical mucus observations. We understand the physiology. So, you know, from a scientific perspective, there's only 6 days in the cycle when conception is possible. And so there's a number of different research studies that have looked at this. And when you understand the physiology, so outside of the fertile window, the cervix is closed and it's filled with a thick mucus plug that prevents sperm from entering. And so it's only as we approach ovulation and we start to see cervical fluid that the cervix is open and that the sperm can actually survive inside the vagina and the reproductive tract for any significant period of time. And so the cervical fluid that we produce, the clear stretchy egg white or the creamy lotiony, it changes the pH of the vagina. Outside of the window, the vagina is acidic and we just kill sperm left and right. It's really interesting, fascinating actually. But then in the window, that's the only point in time when the sperm can survive long enough to fertilize an egg. So, you know, a big part of it is a shift. We have to kind of break the myths. We have to start understanding, like, what is the physiology of the female reproductive cycle? How does it work? What are these different components? And when you understand that, and then you choose a specific method of charting, I recommend to learn from an instructor, especially for women who are wanting to use the method for birth control, because of course it is possible to misinterpret the information, or if you're not, it's like driving a car. Like if you don't learn all the road signs and you don't really get the proper instruction, then of course you could make mistakes. But when you use the method correctly, you understand how to identify which days are fertile. You understand how to identify when ovulation is happening in the cycle. And of course, even though scientifically there are these 6 days, so 6 days because mucus keeps sperm alive for 5 days and ovulation only happens on 1 day. But when you're using a specific method, you have to add time, a buffer period to that to make sure that you've confirmed ovulation, et cetera, et cetera. So using the method for birth control is possible. And it's basically, what I teach. And although there's some complexities and it takes a bit of time to learn, if you're working with an instructor, you can really start to gain a good understanding within 1 to 2 cycles when you're learning with an instructor. And then when you're learning on your own, then a minimum of 3 cycles so that you have an opportunity to actually chart and understand. But of course, as an instructor, I recommend learning with somebody because I think that it's just important. And then for women who are trying to conceive, it's a little bit different, but still important to understand how the cycle works. It's possible to inadvertently reduce your chances of getting pregnant when you follow, for example, like if your practitioner tells you, okay, just have sex between days 12 and 16 or whatever. For some women, they might inadvertently be preventing themselves from conceiving. Ovulation can happen earlier or later. So I think we often think, oh, it only matters if she's trying to avoid pregnancy, but it actually matters both ways.
Right. I think it's a good point. When you were talking about the mucus, right, you're talking about the different texture of it and the color of it. What are the other things that a woman should be aware of when they're taking a look at the mucus that they see? I mean, obviously, textures, colors, what are some of the key things that they may be able to pick up by just even seeing the different color of the mucus?
Well, that's a really good question. I mean, there's 2 main types of mucus, like peak, which is the clear, stretchy mucus. When you're wiping, often women will notice a lubricative sensation. So they'll go to the bathroom and it'll be like, whew, really slippery. And then the non-peak, which is more of the lotiony, kind of cloudy type of mucus. So when you're approaching ovulation, both types of mucus are fertile. I think that's the most important thing. And so depending on the different methods and the different information, a lot of women who use different charting apps would identify like sticky, creamy, and egg white, but it's basically the same thing. So first and foremost, all mucus as you approach ovulation is considered fertile because of how it changes the pH of your vagina and it can keep the sperm alive. And so I think one of the misconceptions is that, say, one type of mucus is more or less fertile, but I always say, like, you can't be more or less pregnant. Like, you're either pregnant or you're not pregnant. But with that said, the clear and stretchy mucus is optimal for fertility when you're trying to conceive for a couple of reasons. One is that the clear and stretchy mucus has more of those sperm-friendly qualities in greater quantity. And often that clear, stretchy mucus is produced closer to ovulation, because the mucus that you see, the varying types and also the quantity of it is in direct response to your rising estrogen levels. So typically when your estrogen levels are the highest, and that is kind of around that time, once your estrogen reaches the peak, that's what triggers your LH surge, that's what triggers ovulation. So it's really correlated with what you're seeing. And so within my world, when you're looking at a woman's mucus pattern on the chart, some women will have it where they start to see some of the lotiony stuff and then they start to see the stretchy stuff. Some women don't necessarily have enough that they can stretch between their fingers, but when they go to the bathroom at a certain time of their cycle, they'll notice that it's actually more slippery. Just to kind of, because I know women are kind of on all ends of the spectrum, but you can kind of monitor the hormone production based on what you're seeing in the cervical mucus. So the clear, stretchy, and abundance means the estrogen is higher. And then after you ovulate, progesterone shuts that down. And then you go from seeing, this mucus that you can observe to dry days is what we refer to it. But basically it puts the mucus plug in place in the cervix so you don't see anything anymore. I hope that answered the question.
Yeah, I think it gives a general answer to what we're looking for. I mean, obviously, that could be a whole day of just talking about the mucus and stuff. But I just wanted to have you explain that a little bit further. So we're getting to that point where we got to start to work on wrapping this up. So like, tell us a little, like if a woman's interested in looking at fertility awareness, where does she go? Where does she get more information? I mean, obviously you have a book that somebody can definitely go to Amazon, get the Audible version or the written version. The fifth vital sign, but what do they need to understand if they want to try and do this in a more natural way?
Well, I mean, there's lots of resources. Of course, as you mentioned, they can grab a copy of the fifth vital sign. Taking Charge of Your Fertility by Toni Weschler is, for many women who are in this area, the first kind of port of call. So it's like the fertility awareness Bible. So that's a good place to start. You can look in your area to see if there are fertility awareness professionals. You can Google the Association of Fertility Awareness Professionals for a list of certified women who are certified to teach. So again, it's important to know that there are different methods and different organizations that teach this. So it's a really good idea to work with someone who's been certified in a particular method so that you at least know that the person has training. Especially these days, fertility awareness is becoming a lot more common and a lot of women are advertising themselves. So it's really important to work with someone who's been trained in a specific way. So in addition to that, I've been podcasting the Fertility Friday podcast for almost 5 years now. And so there's lots of fantastic and free information about charting on the podcast. And then if anyone's really interested in wanting to jump in, I have a free 3-part video series that just takes you through the basics of mucus and basal body temperature and cervical position. So that's at fertilityfriday.com/FAM, FAM 101. But yeah, that would be my best recommendation there.
Awesome. Erica, any final questions?
No, I think we've covered it very well. I think that listeners just need to, just like with thyroid, you need to take a hold, be very in tune to your body. And I think your cycle is a great way that you can, learn more about your health and to know about later on in life if you're, wanting to be fertile. And those are just great ways to track. And like you said, I think it's a great thing to call it the fifth vital sign.
All right. So we'll wrap it up with that. Lisa, thank you so much for coming on. We'll put your social information so people get a hold of you. And if you're interested in more of this, obviously, go check out the fifth vital sign and Fertility Friday on her podcast. Yep, there's the book. Awesome. So I congratulate you on the book. I'm just finishing up mine, and it is something somebody said to me was, you by the time you get done writing it, it's a love-hate relationship because you're excited about it at the beginning and then you're just ready to be done by the time you get done writing. So I've met both both aspects of that, but I give you kudos for getting the book done. It's not the easiest thing to do and knock out, especially with how much citation you put in references in yours. You did a good job doing the work behind it. So thank you so much for being on. I got a bunch of questions that I didn't get answered, so we may have to have you back on and talk about this a little bit more in detail. So Lisa, thank you so much.
Well, thank you so much for having me. It's my pleasure.
All right.
Thanks.
All right. Take care, everybody.
Bye.